as a general statement, chemotherapy causes a relative increase of cancer stem cells. Because let's say it's 3% of the tumor, but now you've debulked it and gotten rid of all this rapidly growing stuff. The cancer stem cells, as a general statement, they're slow growing. They just sit back. They give the chemo, they figure out how to kick it back out and become resistant. And that's why I say, well, this is not working now. It's because the cancer stem cells got the exposure and have now upregulated so that they can kick the chemotherapy back out again.
Dr. Christine Salter, it's great to see you. Great to have you on the podcast. How are you?
I am great, and I'm happy to be here.
So we met at the Beljanski Foundation conference in Florida.
That's right.
A couple months ago, and had a great conversation, and in fact, several conversations that really got me excited about interviewing you and sharing your knowledge. You're working with cancer patients, and you had told me things that I had never heard before. And I think some very important things that patients need to know. And so I'm excited to dig into your knowledge and experience and share that with my community. But why don't we start with your story first? Do you mind sharing a little bit of your background, how you arrived at where you are now, your sort of health and holistic practitioner journey?
Yes. So I'm originally from the UK, born and raised in England. My parents emigrated there from Jamaica. And so in England, I did my bachelor's biochemistry and physiology. And I was going to pursue becoming a medical doctor. And during that pursuit, I developed a neck issue. And I went to my GP, who's known me, since I was a child, and basically she didn't touch me. Very sweet lady, but she didn't actually physically examine me. She just started writing, a prescription, which totally didn't help, and just really got worse until somebody recommended that I see an osteopath. And of course, back then, on the national health system, osteopathy, naturopathy, acupuncture, none of that, you didn't even really know about it. And so I didn't know what an osteopath was, but my friend recommended that I see one, which I did. And in 2 treatments, that pain that I'd been having for like 5 to 6 weeks was gone. And I thought to myself, wow, here I am trying to pursue, regular medicine. My mother was a nurse. And so, that was the way, she said, yeah, you can be a doctor, so you pursue medicine. But then when that happened, I said, well, I don't want to do that. I don't want to do that. It didn't help me one bit. And so I kind of looked at where I could train to be an osteopath. And then that's where I found the British College of Naturopathy and Osteopathy in London. And so that's where I trained and became a naturopath and osteopath. And I want to just make sure I'm clear here. The osteopaths in England are not the same as the osteopaths in the United States. So the osteopaths here are basically medical doctors. I don't even think they even do the adjusting or spinal manipulation anymore. They may do it as an elective. But in England, it's the primary, that's what you do. It's not medicine, it's all natural. And this school combined both of them. So that was my training. That's what I did, and that's what I enjoyed. I was invited by a couple of medical doctors from Alabama, actually, to join them there to Lifestyle Institute. And they were really interested in osteopathy. They were doing lifestyle. They were from my church. And so I said, well, of course, and that's what I do. And so when I came over and wanted to stay, when I looked around to see what was equivalent to what I'd done, it obviously wasn't osteopathic medicine because I was a medical doctor. So what it was chiropractic. Naturopaths are still not licensed, and that was over 30 years ago that I came. Naturopaths are still not licensed here in Missouri, and in several states are not licensed. I did not want to be an unlicensed practitioner. So I matriculated from Logan College of Chiropractic, now university, and actually joined the faculty there after graduation. And I was able to practice, basically naturopathy and osteopathy, in the way that I, really wanted to do that. But then the word kind of got out that, there's an osteopath. And so they kept thinking that I was like a medical doctor. So I had people coming to me, so I was a medical doctor, but I wasn't trained as a medical doctor, in no shape or form, except, good anatomy, what I did well, but I was not a medical doctor. And so at that point, I prayed about it, thought about it, and that's when I went to St. Louis University School of Medicine and did become a medical doctor, and then went on to be board certified in family medicine, and then integrative holistic medicine, and then just continued in that journey of now. So now I combine everything together. But I started seeing patients with cancer really when I went to UT Pines there in Alabama back in 1987, and continued with that just steadily over the years, and they've just really, gotten in real depth into it now. And so I see oncology patients, along with their medical oncologists or radiation oncologists, and sometimes some of them have chosen not to even deal with them. And so I will still work with them the best that I can.
What's the difference between osteopathic medicine and chiropractic care? Okay,
so if you talk to a British osteopath, right, the real, they'll say, don't ever go to a chiropractor. In fact, that's what I said when we did our training. They'll go, don't ever go to a chiropractor. They don't know how to adjust you properly. They'll break your back. They'll do this. I'm like, oh wow, really? And then I came to the US and doing the chiropractic training, and they said, don't ever go to an osteopath. They don't know what they're doing. Right? So they both said the same thing. And then it turned out that the manipulation, or so osteopathy says manipulation, spinal manipulation, chiropractic says adjusting. It's essentially the same thing. What they both achieve is actually, it's not really, because people talk about bones being out of place. There are no bones out of place like that. It's a functional, and it's a way that it impacts the nervous system. So everybody should be either getting chiropractic care or, the original osteopathic care to have their nervous system functioning properly. So that's really what it's about.
And explain really that. How does spinal manipulation or adjustments, how does it affect the nervous system? And I imagine there's also benefit if you have muscle tension, right? If you have
absolutely. And part of the treatment is to we do postural assessments to see how the patient is standing and how they're using their body, and then we look at the muscles. If they've got pain, you've got to identify the pain source, because there's no just point in randomly treating. You've got to identify the pain source. But the nerves supply the muscles, supply the ligaments, okay? And so when you do work on the ligaments, the muscles, or adjust the spine, that fires in to the nervous system. Very often when there's a problem, we call it somatic dysfunction in osteopathy. There's what's called a central excitatory state, and so everything's just really kind of almost on a hyper alert. And by doing the adjustment either manually, a very quick adjustment, or using an instrument, it basically interrupts that. Okay, and then of course those the nerves supply organs, right? We've got the somatic nerves. We've got the visceral nerves, the autonomic nervous system. So it's very powerful. I can adjust the thoracic area, and it impacts the cardiopulmonary. So if someone's got asthma, if they've got COPD, we have that aspect. So it's just very nice to me. That's true holistic, right? You're addressing all of the patients, not just, okay, well, I'm just going to deal with their muscles, okay, or I'm just going to deal, with the ligamentous structure or whatever. Everything is tied together. You just can't separate it. The nervous system, the circulation, everything is tied together. The nerve supply, the vasculature. Then we've got the lymphatics. So you've got to address everything and see really what is the problem when a patient presents.
I love the fact that you have such a comprehensive, medical education. I mean, there are very few people out there that are trained as a naturopath, osteopath, medical doctor, and chiropractor. I mean, to me, that is just so remarkable and wonderful, because you have such diverse toolkit. And, and I know you've done even additional training beyond those things. That I imagine it in some ways, it must be hard to juggle all that information, to keep it all sorted in your mind. But at the same time, like, that's the kind of person I would want to work with, is someone that is coming from a comprehensive, holistic approach that's trying to do no harm and get to the root cause of my problem.
Right. And that's exactly what I aim to do. Yes, absolutely.
So in working with cancer patients, one of the things that we talked about was how important, you expressed this to me, and I was fascinated by it, but how there are steps that a cancer patient can take to reduce their risk of metastasis around surgery, correct?
Yes, absolutely. Absolutely, yes. I share with my patients when they come, when you have a primary tumor, that's what's really just looming, and understandably so, especially if it's a big tumor. But that big tumor is driven by cancer stem cells. It's by stem cells. So if you've got this big tumor, 95% of it is the primary tumor. And unless it's in the brain, so that's a different thing. Okay, but if it's not in the brain, that primary tumor is not what really causes the demise. It's the cancer stem cells. They're the ones that cause the primary tumor to grow, and they're the ones that go and cause metastatic disease. So when a patient comes to me, I'm already thinking about how am I going to reduce their chance of metastatic disease, because from a year from now, 5 years from now, 10, 15, 20, 30 years from now, that's what I'm thinking when that patient presents to me. Yes, we want to debulk the primary tumor, and there's different ways in conventional, the three main ways now, right? Surgery, chemo, radiation. Okay, that's debulking the primary tumor, but the literature shows that doing that actually then increases, or have a relative increase, of the cancer stem cells. And that's why the literature also shows that simply shrinking a tumor doesn't change the overall mortality. So when we're jumping down and say, well, the tumor shrank, in the patient's mind, they're thinking, I'm getting better, right? I'm going to live longer. The literature doesn't support that. So we just have to be clear on really what we're doing. We have to say, yes, we're going to deal with the primary, but at the same time, we have to address the cancer stem cells. And so in many cases, there's often a surgical resection. Now, in breast cancer, they've recently changed where they do the chemo first. And they do the chemo first to shrink, and then they do the resection if the tumor is not completely gone, but usually it hasn't completely gone, and you still end up with a resection. Okay, colorectal, depending on the size of the tumor, again, it's usually surgery first, and of course, depending on whether it's the right side or the left side, you just say colorectal cancer, but a right-sided tumor is very different from a left-sided tumor and is treated differently.
December 2003, the standard of care was surgery first, but it has changed.
Okay.
But I did just see, sorry to interrupt you, I did just see a study a few weeks ago published indicating that now, according to this one study, that they're thinking, well, maybe the chemo first isn't helping, actually. So anyway.
The thing is, what happens with surgery, and any surgery, is that, first of all, the patient's stressed. The patient is stressed heading into the surgery. Then you get to the surgery, and the anesthesia that's used, just the process of having the surgery, being cut on, all that, it causes an immune suppression. And so when there's immune suppression, well, what happens during the surgery? Those cancer stem cells have an opportunity to move through. Now, I've checked circulating tumor cells just after a biopsy, like after a prostate biopsy, and you see them go up. Well, of course it's going to go. It's mechanical, right? You're sticking needles in. Things are going to move through. I mean, we've got our head in the sand to think that, oh, there's nothing's going to move through. So it's not, the problem isn't that the stem cells go up, but as I track them, then you just see them disappear. And why do they disappear? Because the immune system goes after them and takes care of them, because that's what the immune system is designed to do. Okay, so we're not going to go, oh my goodness, the cancer stem cells increase. No, we said, well, it's going to increase. It's just a traumatic procedure, and then the immune system takes care of it. But now, a biopsy, you're not under, you may have some local anesthesia, but you're not under the major anesthesia now, where you've got this immune suppression, okay, and all that happening. So with that now you've got the combination of cancer stem cells moving through and immune suppression. Now that's a problem. So now the immune system is not going to do what it's supposed to do. It may see those cancer stem cells, but its ability to clear them has now been compromised, like totally compromised. And so now, and because the primary tumor will often send signals to what we call, to pre-metastatic niche. They'll send it to the liver, send it to the bone. Bone is a common one, right? And so some of them have already gone, okay, but they're just hanging around. Now you come with the surgery, and more are released, but now you've got immune suppression. Okay, so now they're not going to be removed as well, and so it just takes a matter of time, right? A matter of time before you'll hear, oh, we've got everything. This is great, complete resection, no lymph nodes, no this, no that, and then 2, 3, 4, 5 years, it's in the lungs, it's in the bones, it's here. You say, well, wait a second, you told me you got everything. How could that be? Well, that's how it is. It's the cancer stem cells, and very often they're not even measuring them. They're not even preparing you for that surgery. Unfortunately, maybe the medical oncologist would say something, but they've not been to the medical oncologist yet. They've seen the surgeon. The surgeon, his job is, or her job is, to go in and get the job done. Let's get this out. They're not thinking about immune suppression and this, that, and the other. So with colorectal cancer in particular, there's a couple of medicines, some prescriptions, and one over the counter. A lot of cancer cells, often you'll see an upregulation of different receptors, and one of them for histamine receptors. Okay, and they're just upregulated, and so there are studies with breast cancer where using Claritin has improved survival. Okay.
Claritin, the antihistamine.
Yeah, antihistamine they take for allergies, right? Mm-hmm. So part of what I do is called,
and they'd be taking it around the surgery, taking it before and after surgery.
Before and after, but with cancer, when the studies, they've just shown just using that in general for breast cancer, they've had good outcomes with that. Period. Okay. For colorectal, what they've used is actually cimetidine. Over the counter, it's Tagamet, right? So I'd usually write as a prescription, and then all of a sudden, now we can't get it as a prescription. It's just so very hard to get. So I said, it's fine. I just tell them, go get it over the counter. Do the proper dosing. It's usually 400 milligrams twice a day. And so the difference between the prescription and the over the counter is just the dosage. So I can write a 400 milligram prescription to be taken twice a day. If we can't get that, then we simply go get the Tagamet, and they're 200 milligrams. You just take 2 of them twice a day. And you start before the surgery, and you continue. Those ones that are with that can continue for a whole year. Okay? But you actually can just do it perioperative and do it for like a good 2 weeks. I like to do when everything's all settled down, all the inflammation is, kind of gone away. So, you're talking, I like to do like 4 to 6 weeks, so just a nice amount of time that everything's nicely done. So there's that for the histamine. The second prescription medicine is a beta blocker. And a simple beta blocker, I prescribe this in residency, propranolol, for people with stage fright, when they get all anxious and and their heart rate's going up and they're getting, all anxiety. You put them on that beta blocker, calms everything down, and they can go on stage without any stage fright. One of the drivers, and a big driver of metastatic disease, is sympathetic stress. So that's why when I read the study with breast cancer, where it showed a decreased progression and this whole thing by doing yoga. And so that really got me thinking. So I said, wow. So that relaxation that happens to decrease that sympathetic drive decreases metastasis. So I will put patients on beta blockers starting a week before surgery, take them all the way up to surgery, and then for a few days after. If it's colorectal, for sure, I'm going to do cimetidine. And then thirdly, there's anti-inflammatories, because that inflammation is also a driver that causes the suppression. So it's just like a perfect storm. You've got what's going on with the tumor itself. You've got what's going on with the patient being all stressed and the system being distressed. And doing these three or four, even in breast cancer, there's studies using Biaxin, clarithromycin, also decreasing metastatic spread and recurrence. So for breast cancer, because the data is there, I'll do all not the cimetidine, but the other three. What
was the last drug you said?
Clarithromycin is an antibiotic. Actually, the name is Biaxin is the name for it. There's a very interesting study with that in breast cancer, and so it's so simple, and that's what's heartbreaking for me. It's such a simple thing to do. If the surgeons would simply do that, and now I work with a breast cancer surgeon locally. And for when I looked at the data for breast cancer, it's basically say before that first incision, you make sure you drop in a non-steroidal, right? And the study was done with ketorolac, IV Toradol, and that's exactly what she does. We have that conversation. We talk about the type of anesthesia, because certain anesthesia, the inhalant anesthesia, can cause more immune suppression.
Wow.
Okay. So I usually have them ask for the total intravenous anesthesia. Now there is one inhalant, particularly for colorectal, sevoflurane. That one's actually protective. So you just got to know what you're dealing with, right? It just can't be just blanket, right? So it's like if in an inhalant anesthesia, we'd use that one. Or we do the total intravenous anesthesia. And then we talk about the pain control, because the opioids also cause a problem and can drive the cancer, right? Yeah, so you see, so I say to my patients very categorically, I said, you ask them, you say, I do not want any opioid medicines, right? I don't want morphine. I don't want hydrocodone. I don't want oxycodone. I don't want any opioids. I want, non-steroidal anti-inflammatory. I want Tylenol. Now, all these drugs have their issues, right? So, if I have patients taking Tylenol, I say make sure you take milk thistle, right? Because that will protect the liver, okay? And there's studies that show that it does do that, okay? Or an acetylcysteine. That's the drug that's given when someone does a Tylenol overdose. Mucomyst. It's NAC. So if somebody has got chronic pain and having to take chronic Tylenol, well, yeah, we're going to mitigate that. Non-steroidals can raise your blood pressure, right? So chronically taking non-steroidals is not a good idea either, right? But in this perioperative setting, we're going to do the non-steroidals, right? Because it's not going to contribute to the metastatic spread. So if they will address the anesthesia, address the pain medicines, address what's going on with the tumor itself, and then address the sympathetic drive. You've got a beautiful situation where you're going to dramatically reduce their recurrence. And the surgeon, when that patient, when they get the recurrence, the surgeon's long gone. That procedure is done, boom, it's gone. Now it's on to oncology. Now it's on to the medical oncologist, right? And, medical oncologists are not thinking about surgical and perioperative this and none of that, you see? And, so it becomes problematic. And it becomes even more problematic if chemotherapy is added to the mix, right? Because as a general statement, chemotherapy causes a relative increase of cancer stem cells because, it was just 1% of, let's say it's 3% of the tumor. But now you've debulked it and gotten rid of all this rapidly growing stuff. The cancer stem cells, as a general statement, they're slow growing. They just sit back. They, give the chemo, they figure out how to kick it back out and become resistant. And that's why I say, well, this is not working now. It's because the cancer stem cells, got the exposure and have now upregulated so that they can kick the chemotherapy back out again. Okay, so if they have, especially if the worst thing is to have chemo and follow it by surgery, right? Because now you've debulked, you've got relatively more cancer stem cells. Now you're gonna go to surgery. Do you see? That's a bad combo.
Well, and it should be mentioned that chemotherapy also wipes out a lot of your really important immune cells.
Exactly.
So if you've gone through chemo, you have a decimated or reduced immune cell population. And
exactly.
Surgery.
Exactly.
You have the stress and trauma of surgery. You have immune suppression from the surgery.
That's right.
And they give you opioids, which suppress your immune system.
Even more. Exactly.
There's this cascade of negative effects. And I think that there's a big lesson here. I just love this interview so much. I can't wait to share this. But there's a big lesson is that I think a lot of lay people and doctors assume wrongly that that many pharmaceuticals are benign, right? That they're benign, that the anesthesia doesn't make any difference toward helping your immune system or helping cancer grow or spread, that the opioids or the painkillers don't make any difference. And so they're using all these drugs that actually can be pro-cancerous or anti-cancer.
Exactly.
And then, know.
And then also the nutrition too. I mean, that's huge when they say, oh, it doesn't matter what you eat, just go eat whatever you want. Really? So you're going to go to do chemo when we know that sugar will lower the immune system for what, 3 to 4 hours? So let's it doesn't make sense. I mean, it's not being thought through properly. Now there's a time and a place to eat or drink something high glycemic, and I'm going to mention that now. And it's right before you do the chemo, right? Right before you do the chemo.
Okay. Why?
Because the cancer cells, for the most part, love glucose. They upregulate those receptors so they can just suck that in. So the ideal thing, and there's studies on this, around the time of chemo, to fast. So you fast before the chemo. So now the cells are starved. They are stressed and distressed. Okay, some of them might even die, but there are going to be some of them that are smart enough to say, no, we're gonna handle this fasting, right? And so those kind of go into hibernation. They're the ones who want to get within 30 minutes of that infusion, that you drink eat high glycemic, get it in there so that it wakes up those cells so they are ready to, they're like, oh great, I've got stuff coming, right? It's like a Trojan horse, right? And then they get hit with the chemo. So if we're going to do the chemo, we want to maximize and be smart about it. Okay, and then
there is a chemotherapy strategy around this, the insulin potentiated
Exactly. Yes,
Give a
exactly.
shot of insulin that
Ex-
primes the cancer cells,
same,
and then
same principle.
they
Exactly.
deliver the chemo, but it's a much lower dose, so it doesn't do as much collateral damage.
Exactly. And because, in an ideal world, everybody would be doing that. But, this is the poor man's way, right? It's a way of doing it. It's like, okay, you're doing the conventional stuff, let's do this. We might as well maximize it. Do the fasting. And again, let me just say with the fasting, that's as long as you're not already too thin. If you're already too thin, then you can't say you're going to do the fasting. That would be counterproductive. But to do that around, it's very useful. You stress them and then you press them, and it's a better outcome that way. It's a completely better outcome. And then what you do after. So what I like to do is that if they're doing conventional chemo and doing all that, I like to cycle through to help the immune system. You just can't keep hitting them with the immune system, even though they say, well, okay, we're going to do 3 weeks on and a week off. Well, when you do that week off, it should not just be a passive week off, right? Like, we're not going to nail you for a week. No, it's like, no, we're not going to nail you for a week, but we're also going to boost that immune system as well as we can. We're going to get rid of those senescent cells, because those senescent cells that usually accumulate with aging, but cancer and chemotherapy basically accelerates that process. So you get a whole bunch of senescent cells. And what do? They produce a bunch of inflammation. Inflammation drives cancer. So what I have them do is that when on their off weeks, we go after we use the senolytics, and we just hit them hard with the senolytics, clean things up, boost the immune system as well as we can, and then we're ready for the next round. And we just keep cycling through and cycling through and cycling through. It's not enough just to do the chemo and then just say, wow, I'm glad I'm going to take a break for a week, right? And then I'm going to get hit again, right? We have to, rehabilitate that immune system as best we can. The high dose vitamin C, that's very useful. Okay, so, mistletoe, there's all different things that you actually can do right along with the chemo. Mistletoe you can do along with the chemo. Are you familiar with Believe Big?
Oh, yes. I've
yes,
interviewed
yes.
Evelise many
Oh,
years
Evelise.
ago.
Okay, yes. I met her in Germany about 5 or so years ago, maybe 7 years ago. Yeah, so it helps with surgery, chemotherapy, quality of life, and it can be cytotoxic all in itself. So that should be happening all along. Okay, so when you come to that off week,
talk about mistletoe. What is the mechanism of action in the body of mistletoe? What is this compound doing?
Okay, so multiple things. Mistletoe, well, of course, there's all different types of mistletoe. When you just say mistletoe, there's like a ton of different mistletoes. Okay, and some of them have a higher lectin content so that you can elicit an immune response. Okay, and of course, it all depends. We try and target it, and depending on the patient's constitution, the type of cancer. We don't want to be too aggressive if the patient is frail, or too aggressive if the patient's going through chemo. Okay, so it helps the immune system. It's immunomodulatory, just like low-dose naltrexone. Everyone should be on low-dose naltrexone who has cancer. Modulate the immune system, becomes cytotoxic, decreasing inflammatory cytokines. It's great, and it's so simple. It can do it by injection, and we can do it by IV. And sometimes we'll do both of them together. Sometimes we'll do 2 different types of mistletoe together. One through the IV, one they're doing at home. We want to get a nice reaction. When we see that reaction, we know that the immune system has been activated. Now it's looking, right? And that's the issue with a cancering state, is that the immune system, for some reason, has just kind of gotten laid back, and it's just not really seeing the cancer, even though it's staring in the face. So part of what needs to happen is to activate it. And so what happens, we talk about those M1 and M2 macrophages. You're familiar with that, right?
Yes.
So, and it's not that one's good and one's bad, right? Because you don't want to have only M1s, right? If you had only M1s, you'd react to every little thing that, that came your way, right? A little bit of dust, a little bit of this, anything like that, you'd be, eyes running, blisters, all kind of stuff. So we don't want all M1s. We want some tolerance from the M2s. But in the cancering state, and we can look for these in the blood work to see, is it polarized more to M2, right? Is it polarized to M2? So now when it sees the cancer, it's just like, okay, I'm not doing anything. Okay. And then we get this upregulation of these Treg cells, which then continues to stimulate those M2s, and then the cancer itself, it's just interesting, the whole thing that happens with cancer, upregulating and secreting cytokines that triggers the body to go into the M2 state, right? So it's just, designed to say, okay, this is the way we're going to protect ourselves, affecting the tumor microenvironment, upregulates glycolysis so that you get all these acids, the lactate. So because all acid, but it can't handle the lactate. So what does it do? It kicks it out into the tumor microenvironment. And so now you've got a relatively alkaline tumor, but a pretty acidic tumor microenvironment. And so now that tumor microenvironment in itself then is creating an even more of a niche to support the tumor itself. So it then sends out cytokines and chemokines to bring in the blood vessels, to bring in those tumor-associated macrophages, to bring them all in so they can continue the same process. And then basically what they want to do, and this is something else that I want to also share, with your audience. There's this thought that, you've got a primary tumor, just leave it there. Leave it there, because if you take it out, if you take up, they say, if you take away the mother, then the children are going to, go, right? And saying that you're going to get metastatic disease. The point is, the longer that primary is there, there's more of a chance for the cancer stem cells to create a program that we call epithelial to mesenchymal transition, EMT. There is more time, so it's time dependent, right? And sometimes even at the diagnosis, when they say, oh, it's just here, it's not in the lymph nodes. In breast cancer, 30% is already gone, right? So the idea of saying, let me just keep this in here, and I'm just going to try and do things, or naturally, or whatever the way they want to do it. We need to remove that primary tumor and at the same time address the cancer stem cell. You've got to remove it, because the more time it's there, it can transition. It's sending all the messages. It's preparing the bones, preparing the liver. That's what's going to happen, right? So I'm not in the camp of let's leave this and see how the body is going to take care of this, because if the body could have taken care of it, it still wouldn't be there now if it could have done that, So my thing is, let's assist the body in a safe way to debulk and or remove that primary tumor, and at the same time, address the tumor microenvironment, address the immune system, address EMT, address invasion, address it all. So we're not putting all our eggs into one basket.
Makes a lot of sense. There was a study that came out in 2018 that I'm reminded of, that where researchers found that the primary tumor is sending out signals, and you alluded to this, sending signals to the immune system that actually help prevent its own spread. Now, granted, we know that primary tumors can spread and do spread, but there is this communication that it's alerting your immune system to the fact that there's a problem, and so there's a bit of it's almost like a catch-22.
Yes, a catch-22. Right? Yes,
because it begs the question, well, if you take the primary tumor out, then does your immune system sort of relax and go, oh, okay, well, the problem, no more problem here, while you still have circulating cancer cells?
Right. So, and that's what, well, the point is the immune system is usually in that M2 mode, right? So even though it's getting signal coming from the primary tumor, it's still in the mode where it's not taking care of what it's supposed to do. So I guess I used to be in that camp until I saw over the years what really happened, right? And what I've seen really happen was not good. So that's why, when you talk about things in theory, it sounds great. Okay, so in theory that sounds really nice. So well, let me just keep it there, and all these nice signals, and it should take care. That sounds nice in theory, but what I've seen in clinical practice, I've not seen that happen. You see, so again, my position is do it safely, and activate that immune system. And not only that, so this is something really interesting. So I was just in Germany at the World Congress of Integrative Oncology, and was talking about selenium and using, and I don't want your audience to run out and go and get selenium methionine, because then it will become kind of toxic. But you've got to get the right form of selenium under the care of a physician. So what the cancer cells turn out that they have something called parafibrin. And it's a thick coating. So it's got this thick coating, so the immune system can't even get to it, right? It can't get to it. So you could be activating the immune system, but it's simply not doing the job. It can't do it. It can't get to it. And so we want to unravel that and remove that parafibrin. And the 4 nutrients that does that. And they're all nutrients. They're not prescription medicines. One is selenium, selenite, curcumin, EGCG, and magnesium. Right? Okay. So we've put them on that combo. Again, each thing we don't do random stuff. It's got to be very clear what we're doing. Okay, we're doing this for this. Okay, we're doing this for the immune system. We're doing this for the tumor microenvironment. We're doing this for angiogenesis, anti-angiogenesis. We're doing this for anti-metastasis. We're doing this to block EMT transition. So, and then as you go through, either using repurposed drugs or the botanicals or the nutraceuticals, you're going to see that there's overlap. So they don't have to take 100 supplements as long as you know what you're targeting. Right, and when you know and you go through your checklist, that's the one thing I like about conventional oncology. It's very crystal clear. They're doing this for this, this for this, this for this, right? Not overlapping and saying, well, this is great for this, so I'm going to use 10 of them, right? If they're not, they're going to say, okay, we're doing this, we're doing this, we're doing this. So I like that mechanistic way of thinking. We're going to hit all these different pathways that are so important for the process, for this cancer process, the cancer stem cell signaling, the Wnt pathway, the hedgehog pathway, the Notch pathway, the STAT3. You don't take in a ton of supplements and then you realize they're all hitting the Notch pathway. They're not touching the hedgehog, and they're not touching the beta-catenin or Wnt, right? So we want to make sure that we're hitting the signaling, their metabolism, everything, right? And you do it all at the same time. We don't do it sequentially because we don't want to kind of get used to, I can deal with this, right? We want to make sure we're hitting all those pathways at the same time and doing everything at the same time to get the biggest bang for our bucks. We don't want to give them an opportunity to say, well, now I can go down the Notch pathway because that wasn't covered.
Something you mentioned earlier that I wanted to touch on was you mentioned chemotherapy shrinking a primary tumor. And I think a lot of folks don't understand what's happening when a tumor shrinks because they don't know, and they have been told that a primary tumor is not 100% cancer cells. A primary tumor has immune cells in it.
Right.
And it has macrophages in it. It has T cells in it.
Yes.
And so those cells die off during chemotherapy, and that does shrink a tumor. So you can shrink a tumor with chemo and have not even killed any of the cancer cells in the tumor. You just killed the immune cells that are in the tumor. So that's, it's sort of like a false sense of security.
Exactly.
In oncology.
exactly. And the converse is also true. So what can happen, you can be doing protocols that go against, that's, activating the immune system. Because now we've got immunotherapy, right? Targeted therapy, and we've got immunotherapy. Well, when you do an immunotherapy, it's going to cause, a lot of turbulence and activity. So you may see things get a little bigger, right? But we don't jump up and down about that. And that's why you have to be real cautious of when you do your repeat imaging studies, right? You do all your immune stuff, even doing the high dose vitamin C and all that, and mistletoe and all that. You're basically getting the immune system to go after this stuff, and so the tumor markers are going to go up. You may see enlargement, in the liver or the lung, but you've got to wait. You've got to watch other things, right? I like to follow like VEGF, MMP9, the markers that tell me invasion is really happening, right? So if I see those going down, and even if I see a little bit of enlargement, in the liver or the lung, and I see the other stuff going down, that's the body fighting it. That's the body fighting. That is not invasion. Now if that's going up there, and those things are going up, now that's a different animal. But again, it can't be. You can't be robotic about it. Okay, you've done this. Okay, now we're going to do this imaging. Oh, it's gotten bigger. Oh, we're going to change the protocols. But wait a second. Let's really make sure that this is not pseudo progression. We don't want to change anything if it's really working, right? Yeah. And so again, you've got to do more blood work than simply do a CBC and a CMP, right? CBC, CMP, tumor markers. That's all you see. You've got to go a little deeper than that to say what is happening here, what is actually happening. Because some things when they go up, like that AL2 receptor, that's fighting. So when I see that up, I say, okay, good, it's doing what it's supposed to do. In early prostate cancer, if we see an elevated transforming growth factor beta, we're happy about that. If it's advanced, we're not happy about that. Okay, and so you've just got to look at the markers in the context of what's happening. That's what we need to do, and it's just not cut and dry.
That's really important. Context is so important, and just understanding that inflammation and pain do not necessarily mean you're getting worse. They're also part of your body's healing response.
That's part of the healing response, exactly.
Right? And without the right kind of testing and the right practitioner to really look at all of these important markers, you don't know, right? You don't
exactly.
Inflammation and or increased pain is a good thing or a bad thing.
Exactly.
Everyone assumes it's bad.
Exactly, right. Well, because we're in a pill for an ill, right? I've got a headache, I need to take this. I've got this, I've got to take that, right? Instead of saying, well, why do you have the headache? Is it because you've not opened the windows and, the oxygen is not great, right? And, you're not breathing fresh. I mean, it's something that simple. Or is it because you're not drinking enough water? I mean, for sure, we don't have a Tylenol deficiency to give us the headache, right? So I like to, when people have got a headache, give them the water, do a water flush, then tell me about your headache. Usually the headache resolves. Go outside, get some fresh air, get up and move so you're not being stagnant, and you'll see that it goes away, right? So again, it's just, that pill for the ill, you got this, I'm going to give you that. Nobody wants to kind of ride it through. I'll tell you this quick story. When I was a resident, for my naturopathic training, you don't suppress the fever, right? You don't suppress. You allow the body to move through, because when the body creates the fever because it's trying to heal. It's creating the fever because it's trying to get rid of that microbe. So but of course you're not going to feel good, so you don't feel good. So then because you don't feel good, I want to take some Tylenol because it's going to make me feel better. I will take some ibuprofen, it's going to make me feel better. Well, you may feel better, but you're not getting better. You may feel better, but you're not getting better because the process is getting worse, because now you just thwarted what the body was trying to do. So when as a resident, I would never write for the standard order for the Tylenol, because the nurse would say, I want a standard Tylenol order for temperature above 1. I said no. I need to follow the fever curve. I have to follow the fever curve. And I need to know that, things are getting better. Now, if someone's in severe congestive heart failure, where they could decompensate if they get a high fever and the heart rate goes up, well, that's a different animal, and we have to do that individually. But I'm just talking as a general statement. Someone's in there, they're in there for pneumonia, they don't have congestive heart failure. I want to know that if I put them on an antibiotic, that the antibiotic's working, and if I'm seeing a fever, I'm like, okay, these things are working, the body's mounting a fever, and then when that fever breaks naturally, you know that the body did its job. But if you just cover it up with a Tylenol, you have no idea what's happened. It's going to be driven deeper, and they may feel better, and then the next minute they're in because they've got something even deeper going on. So I really discourage that, especially with children as well. It's very, very, very quick to give the children the Tylenol or the non-steroidal, and that's the worst. That's just the worst thing. But parents, you don't want to see your child uncomfortable. But if they could, when I was a resident on pediatrics, the pulmonologist, he gave us a brilliant paper, and it's called Fever Phobia, and he says read that and understand that. Right? You've got to be able to educate the parents. To throw away the thermometer, right? Throw away the thermometer. Look at the child and identify, does this child look sick? Not about how high the fever is. Is this a sick child? No eye contact, doesn't want to eat, right? Not doing their normal stuff. That's a sick child. On the other hand, child can have, like my daughter when she was little, raging fever, but bouncing around the house doing all the stuff. I'm not going to give it some time. No, I mean, we'll call it a little chocolate drop because she's kind of dark skin. But when she got fever, a little cheeks were all flushed and she'd be bouncing. I mean, she's back at 102, but she'd be there playing, bouncing around. Do you think I was going to stop her or do it? No. What I did, I chased her around and gave her distragulus and gave her elderberry to help the process, right? To help the process.
What helps me, and I'm so glad you brought this up. Thank you. Whenever I have a fever, I just remind myself, of course it's miserable, right?
Right.
When you have a fever, you are not feeling good. You are feeling bad. And some people tend to panic when they have a fever or when their child has a fever. They kind of go into a panic mode.
Yes. Yes.
Really, I mean, if you got a 101, 102, I mean, it's like you can't sleep. Your head is pounding.
Right. Yes.
You're
yes.
in rough shape.
Yes.
But it helps me to remind myself that right now, as bad as this is, as unpleasant as this is, my immune system is kicking butt right now.
Exactly.
And I don't want to interfere with the process. And that's what painkillers do, is they reduce the fever, and then it reduces the activity of your immune system.
Exactly.
And it prolongs your condition, your disease or infection.
Exactly. Now, let me just say this. So one of the fears with parents is, you can get the febrile seizures. Okay. But they're thinking that it's basically how fast you get to the change, the delta, right? So if you know like a 98.6, and then in a few hours you jump to a 101, right? Then sometimes the child can seize, okay? But the answer isn't to shut the fever down, though, right? Okay, so. And there's a genetic tendency for that to happen, right? Or maybe a familial tendency. So that's part of the fear. But again, shutting down the fever, you kind of biting off your nose to spite your face, right? Because you're worried that there may be a seizure. Do you see? Now, what they can do is give a medicine that will kind of relax the nervous system, still allow the fever to do its thing, but then decrease the risk for seizure. So there are ways to get around that. But just going and giving them the Tylenol, and then what they'll do Tylenol on this hour, and then ibuprofen the next hour, and they're just really doing it around the clock to just shut this thing down. Now there's a real issue with like iron poisoning. So because a lot of iron tablets, they look like candy to children. Now that will uncouple and cause a fever, but that's a bad fever. That's a fever, right? Because that's a toxic fever. That's not what we're talking about. And we're not talking about heat stroke either, where the temperature goes up. We're talking about you got an ear infection, you got a lung infection, you got this infection. The body says, oh, I've got to clear that. I've got to mount a fever to do that. That's what we're talking about where we say you ride the fever curve. So I want to make sure we kind of give that clarity.
Yeah. And, you can Google this too, by the way. If you Google how high a fever is too high, you will find numerous, hospital websites, medical websites, all sort of confirming the same thing. Like, a fever up to 104 is not necessarily dangerous or something.
No, exactly. No, exactly.
Even though it seems crazy.
I know, but that's how the body. I mean, we're fearfully and wonderfully made, yes. Right? So to be able to mount that, to do that, and it forces you to slow down. It forces you to rest. It forces you to hydrate because you're losing the weight. Right? So you hydrate, you slow down, you sleep. You do all those things that you need to do.
Yeah. The other thing, since we're on this topic, the other, I guess, silver lining. Yes. Of getting the periodic flu or, fever inducing, yes. Upper respiratory infection or whatever, is that, while your immune system is fighting this fever, it's also clearing house. Right?
Exactly.
Those immune yes. cells, I mean, they are scavenging, they are killing all kinds of stuff,
exactly.
including cancer cells.
Exactly.
So it actually is a wonderful sort of seasonal house cleaning that happens.
Exactly.
And so it's like, I don't enjoy it. I'm not out looking for the flu, but
right.
I get it. I just like, you know what? My immune system's going to clean house. I'm just going to get in the bed and I'm going to ride the lightning.
Right. Exactly. And you know what?
Through it.
Yeah. But actually some of the hypothermia is part of cancer treatment. Right, raising the temperature because the cancer cannot handle that high temperature. And then there were previous vaccines where they would give the vaccines to cause an increase in temperature. Like the coldest vaccine, that's right, and it would clear the tumor. So doing saunas and regional hypothermia and whole body hypothermia. There are places in Germany where they do that, and now sometimes they do it intraoperatively, and they're heating up the blood because those heat shock proteins, they can't handle it, right? And so we give botanicals and repurposed drugs to block that heat shock protein so that it can't do and try and protect themselves, because they try to protect themselves by increasing those heat shock proteins, and so we try to shut those down. But that's one of the things that mistletoe also does, is that it helps raise the temperature, and the body in the afternoon the temperature gets a little higher, so we like to give the mistletoe in the afternoon, right, to kind of go along with that whole thing, with that warming. So if they say, well, I feel a little warm, I feel feverish, you say great, right? You get a nice reaction, great, give yourself an injection, go in the sauna. Right, so we want to use all the tools possible to go, against the cancer. I've given mistletoe, done heat, injected, do photodynamic therapy, but just kind of do it in a comprehensive way, right, to really disable them. So if if they're trying to get away from this way, well, we've got heat, or we've got hyperbaric. Then you oxygenate and then you heat them up, so. So many things to do as long as you understand the physiology.
Yeah, and I love that. And, there's a lot of the challenge with integrative therapies and non-toxic therapies. There's a lot of them.
There are a lot of them.
And there's a lot of practitioners out there. But it is really important to me to find someone who understands how to best administer these therapies, because right. Many of them have very little risk of harm, and that's fine. But the point is you want to maximize the benefits. So like
exactly.
You're talking about combining therapies together, the timing of them is important, the duration,
exactly.
right?
Yes.
How frequently you're doing them, and then when you're doing what, it's like, so it can get pretty complicated. And for the average patient, or, it's like, when I was sick, I didn't do a whole lot of integrative therapies because I didn't have access to them. So the only thing that I did that would be considered integrative would be IV vitamin C. I had
Oh, that's great.
Yeah, there was a medical doctor, an oncologist, who had sort of become integrative. He was in his 70s,
Oh,
but he
wow.
had shifted into becoming more integrative because he had spent his whole career as a conventional oncologist and was pretty frustrated with the results.
Right.
And
Okay.
so he was doing IV vitamin C, but for patients, and was looking in and researching other non-toxic therapies and studying Eastern medicine in his 70s.
Oh, okay. Okay.
Anyway, but the point is, I did IV vitamin C and
Brilliant.
glutathione together.
Oh, okay.
But what I've heard recently is that actually that's not a great idea to combine those two things.
So,
any thoughts on that?
Yeah, absolutely. So here's the situation: the primary tumor versus the metastatic tumor. So the metastatic cancer actually upregulates its antioxidant response elements. So it wants antioxidants. When it's the primary is different. Although I'm looking at the literature to really make sure that really is the case, I'm kind of leaning away from doing it altogether, even primary, because now we know that the primaries may have already sent off, micro mets. Okay, so right now I've actually moved to position of no glutathione, whether metastatic or primary. But in the metastatic setting, for sure, we're not doing glutathione. We're not doing that at all. Now, could you do it like after, you do chemo, and then in the cleanup? I know one of my colleagues in Australia, during the cleanup phase, they may hit with glutathione, high dose melatonin, and then pull it back, and then they go back to the chemo. It's a nuance, okay? Because we don't want to help the process. And so they're trying to make glutathione, they're trying to do that. So to say, well, here we go, we're going to give IV, or transdermal, our way it's taken, sometimes oral, it's counterproductive. And so you could be doing all these great other things, and on the one hand, while at the same time you're now feeding and helping things along. So yeah, and it's the same principle of autophagy. Everyone thinks autophagy is great, but not in the metastatic setting. And some of the treatments that we do in repurposed drugs and the botanicals, they all increase autophagy. Green tea, mebendazole, like they're all increasing autophagy. So they always must have on board an autophagic blocker. Do you see what I'm saying? Because we can't say, well, we're not going to give you any of this stuff, right? Because you need that stuff because it's hitting other pathways. But if it's also and especially doing, a synergistic and multiple increase in autophagy, well, you may be hitting these pathways and they may be getting disabled. But then on the other hand, now you're providing building blocks for them, right, through the autophagic process. So the FDA-approved autophagic blocker is actually hydroxychloroquine. That is one that, if you Google and say autophagic blocker, that's one that's FDA approved. But propranolol is also an autophagic blocker. Capsaicin is autophagic blocker. So
capsaicin, we like that. That's from red peppers, hot
peppers. Exactly. Those are the peppers. Exactly. Right. So we like to have people on the protocol that includes autophagic blockers, so that we're covering all our bases. And so that's why you hear the stories of, we're doing natural stuff and it seemed to be getting better and then it didn't, right? And part of that is it's doing all this stuff, but now you're upregulating autophagy, then the cancer then says, well, thank you, and then you're going to see the progression.
Explain that process. How does autophagy, generally it's a good thing, but
it's absolutely a brilliant thing.
How is it, when does it become problematic?
Okay, so
how? Like, what is it doing?
So basically, what autophagy does, it basically recycles cells, right? So breaks it down. Okay, the cell is done what it's supposed to do, and so okay, now we can recycle stuff. We'll take the amino acids. We can take this part. We can take that part. Okay, and then it recycles and goes and makes new cells, right? And do we want that? Of course we want that. That happens when we do intermittent fasting, right? That's what happens. And we say, well, that's great. But if you've got a process going on that with rapid growth and it needs all these building blocks, and then you're inducing autophages where you're producing all these building blocks, do you see how it's going to drive that process? So now the cancer's like, it can't handle acidity. It needs more glucose, it needs more glutamine, it needs more nucleotides, it needs all that. So it's like, well, this is great. We're getting all this recycling going on. I'm getting all these nucleotides. I'm getting all this stuff that I'm gonna need. You see, so that's the problem. So, and again, can you 100% shut it down? Well, no, you can't shut it down 100%. Nothing's 100%. You just want to make sure that you're not just doing everything that's going to increase autophagy, right? You're going to have to do some of it, but you just got to be strategic about blockade, right? And that's why, for me, unless a person's got so low blood pressure, I put that propranolol on board, because it not only is it going to block autophagy, it's going to help that sympathetic tone and decrease that sympathetic tone. You have to be a little more cautious with the hydroxychloroquine because there can be drug interactions. So you just have to be careful, because you've got to check every little drug that they're on, everything you've got to look for those cross reactions. But I can easily put somebody on propranolol and not worry about a drug interaction. So that's the whole thing with the autophagy. And again, it's one of those, things that are great when everything's normal. It's not great when you've got cancering state or metastatic cancering state. We have to pivot and do something different. We have to pivot.
Dr. Christine Salter, this has been fun and fascinating. I've learned a lot. I could talk to you for hours and hours, and I hope we can do this again.
I hope so too. Yeah.
Yeah. And just to go deeper and talk about more, because again, this is just scratching the surface of your knowledge, I know, but I'm thankful for you. I'm thankful that you have invested so much of your time becoming a naturopath, an osteopath, a medical doctor, a chiropractor, and, training in all these modalities, and that you're on the front lines helping patients one-on-one. It gives me so much hope and encouragement that medicine is shifting, that more and more practitioners are, and especially the younger generation, are coming up with, coming through medical training with a much more holistic and comprehensive attitude.
Open-minded.
Must have been hard. I did before we sign off, I did want to ask you this question. I just remembered. Was it hard going through medical school with the naturopathic and osteopathic training background, going through this very conventional gauntlet of learning? I mean, did you want to pull your hair out someday?
Yes, I did. It was very interesting. One of my attendings, but actually this is medical school. He had nothing good to say about chiropractic, and so when I've come to class, they had no attendance policies for certain classes, because I already had this other training. I didn't have to attend all the classes. And I remember coming to class one day, and I came in and sat down, and people turned around and they were looking at me, and I was like, okay, what are people looking at? Why are they looking at me like that? Well, apparently the lecturer before just denigrated chiropractic, like they don't know what they're talking about, don't know what they're doing, and this whole thing. And but interestingly, by the end of medical school, his attitude changed. Usually prejudice is based on ignorance.
Yes.
And then until you come up close and personal, things change. Once you have that knowledge and you realize, oh, really, they really do learn stuff. They're not just they go jump around and cracking backs, right? They do know their neuroanatomy. In fact, they know their neuroanatomy more than medical students know their neuroanatomy, right? And so yeah, it was a challenge. And then also during residency, it was a challenge, because the whole thing about the fever curve and this, and then hormones and birth control and all the different things. I'm like, oh my goodness, this is really messing with their physiology. It was it was an interesting time. It was an
Yeah.
interesting time for me. Yes. Yeah.
Yeah. Well, hey, kudos to you for sticking with it and hanging in there and getting through med school. And yeah, because I know it would be very difficult.
But I had my goal. I had my target. When you know your goal,
Yeah.
keep silent, keep on going, because I knew what I was there for,
Yeah.
and I knew what I could do once I was out. So
it's hard enough for any person to go through med school, but then going through with a sort of holistic background and all that training, and not wanting to just fight every day,
right.
argue every day. I know it took a tremendous amount of self-discipline, self-control. So
and
anyway.
a lot of prayer. A lot of prayer.
Yes. God's grace in your life, I'm sure, helped you get through that.
Absolutely. Well, I would like to mention one more thing, though, Chris, and that's for colorectal cancer and actually for breast cancer, lemon balm tea goes after cancer stem cells. Several of the herbal teas go after cancer stem cells. Chamomile, green tea, ginger tea, lemon balm. So I have my patients, for their water intake, not only to drink water, but to drink the herbal teas through the day. And it's just a passive way of going after those stem cells. Earl Grey tea. Okay, so there's all different choices of teas that they can be drinking that are going to hit the cancer stem cells. And so, I encourage that. And it's easy to do, right? It's not like you're taking another medicine. It's easy to do.
Thank you. That's wonderful. And it's amazing because if you dive into the nutritional science research, you'd be hard pressed to find any plant or herb, anything from nature that doesn't have anti-cancer, effects.
Exactly.
It's like, it really is miraculous that God made all these wonderful fruits and vegetables, nuts and seeds, herbs and spices, all these wonderful foods for us that help our bodies stay healthy.
Food is medicine. Food is medicine. Yes.
It really is. Well, thank you again, Dr. Christine Salter. You're amazing. You're just a brilliant person. I'm so glad to know you. And tell me, how can people find you? How can they get in touch with you, or maybe even work with you as a patient?
My website is very simple, www.drsalter.com. So www.drsalter.com. And if they sign on the website every month, I send out something educational. I've talked about colorectal and I've talked about breast cancer. I've talked about heart disease, just different things, just practical things, lifestyle, all that, because the lifestyle is so important. So I do have that newsletter that goes out, each month. And, but if they want to work with me directly, then they can register through the website and it all trickles in.
That's great. We'll link to that in the show notes. It's drsalter.com.
So drsalter.com.
Yeah, drsalter, easy to find.
Yes.
And yeah, that's great. I'm glad we made this happen.
And thank you for all that you're doing. Thank you for all that you're doing. I got your books and it's now in my a link to your website. And when I first see a patient, because you've got the stories that's encouraging. And so, yeah, thank you for everything that you're doing. Thank you.
It's wonderful. Thanks a lot.
Okay.
It's great to be on the same team with you.
All right. God bless.
Okay. Thanks again, Dr. Salter. Hey, everybody. Thanks for watching. And please share this interview with people you care about. Obviously, Dr. Salter just talked about some very critical things that every cancer patient needs to know if they decide to have surgery before going into surgery. And so, yeah, help us reach more people and share the video. And we'll see you on the next one. Bye-bye.